A pulmonary embolism is an obstruction to the arterial circulation of the lung. So we can imagine that the blood vessels going to the lung are taking nutrients and oxygen to the lung, and the arteries get smaller and smaller, like the branches of a tree. And so if you get one of them blocked, then it means that you're not going to be able to feed the lung in the right way. The other important thing is that the pulmonary circulation actually sits in between the right side of the heart and the left side of the heart. So if you get a big blood clot, it actually interrupts the whole circulation of the body. Now, when we use the word embolism, we mean that we're talking about material that's originated somewhere outside the lung, traveling to the lung. And typically, we imagine a pulmonary embolism is a blood clot that's perhaps formed in the deep veins of the leg or the pelvis that then travels to the lung and obstructs the circulation there. Now, it's not always a blood clot. Occasionally, you can get obstruction from a bit of fat from a fractured bone, or even an air embolism. But most of the time, when we talk about pulmonary embolism, we are talking about blood clots. So there are many causes of a pulmonary embolism. Perhaps the one that's most topical is we know that COVID-19 infection is associated with an increased risk of blood clots. And in terms of patients in hospital with pneumonia, we have seen a lot of patients admitted with pneumonia recently with COVID who've gone on to have blood clots as well. The traditional risk factors include patients with underlying heart disease and cancer who are at increased risk of blood clots. But really, even very healthy patients are at increased risk if they have a surgical operation or if they're in hospital for any length of time. And in fact, any cause of prolonged immobility can be associated with an increased risk. So although pulmonary embolism after an aeroplane flight isn't really that common, it's certainly something that everybody is aware of. It's probably true as well that after very long car journeys or any journeys where you're immobile, that you're also at slightly increased risk. Now, for female patients, important causes of thrombosis include use of the combined oral contraceptive pill or the use of hormone replacement therapy. And pregnancy represents a unique combination where you have the increase in hormones that can be associated with a blood clot, but also you can have pressure on the pelvic veins from the growing baby. And so pregnancy is an important risk of blood clots. Now, occasionally we see blood clots in patients who they're not pregnant, they haven't had surgery, they haven't been in hospital. It really seems to have just come completely out of the blue. And in those patients, we often imagine that they've got sticky blood. And sometimes we can demonstrate that by blood tests, and they might have a family history of sticky blood. But in other cases, we find nothing. But we say to the patient, well, you've probably defined yourself as having sticky blood because you have had a blood clot. There is a condition where you can develop a tendency to blood clots, an autoimmune condition called an antiphospholipid syndrome. And that can be associated with blood clots in the veins or the arteries. And that's another important thing that we look for in someone who's had a blood clot out of the blue. So the symptoms of a pulmonary embolism are incredibly variable. Sometimes we have patients who have a CT scan for some unrelated reason, and we're told, actually, this patient's got a pulmonary embolism. And of course, that can come as quite a surprise to the patient. Other times, more classic symptoms would be shortness of breath, particularly when they're going up hills or perhaps when they're walking faster. And then sometimes people can actually cough up blood. We call that hemoptysis. And then chest pain can be a big feature of the symptoms. Now, People are familiar that the chest is here at the front, but what people don't always realise is that the lungs extend right over the back, really down to where your ribs are. And so sometimes patients can present with back pain. And so it doesn't cross their mind it might be their lungs. Or sometimes people have a really severe pain in their side. And often the pain is worse when they breathe in. So these are all indications someone might be having a PE. I mentioned at the beginning that the lungs, the arterial circulation, sits in between the right side of the heart and the left side of the heart. So occasionally, if somebody's had a very big pulmonary embolism, it actually interrupts the circulation and they might start to feel faint or dizzy or even collapse. So sometimes people say they felt lightheaded. Other people might say they almost fainted in the shower. And of course, in some cases, it can actually be fatal. People can actually die. If the patient has symptoms such as fainting or collapse, we would consider this to be a severe pulmonary embolism. Um, and actually, what we look for in other patients who haven't literally collapsed is we look for signs of strain on the right side of the heart, because the blood comes in through the right side, it then goes through the arterial circulation in the lung, and then it goes to the left side of the heart. So if you can imagine you've got a big blockage in the middle there, it's going to put a strain on the right side of the heart. And that might affect your management as well if somebody's got a big strain on the heart. And of course, you're more likely to keep them in hospital for longer whilst everything is sorted out. In terms of the treatment of a pulmonary embolism, our mainstay of treatment is anticoagulation treatment. So that means using treatments to make your blood more thin. And this is to stop the blood clot getting any bigger in the first instance. And then later on, it's all about stopping new clots from forming. So we have these days some what we call the new oral anticoagulants. Of course, they're not really new anymore. So a more common term is the direct oral anticoagulants, or DOACs. And that refers to how the tablets actually work, because they're direct inhibitors of factors in the coagulation cascade. And these are tablets that can be taken by mouth and don't need to be monitored. We used to use a drug called warfarin, um, and warfarin was a fantastic drug actually, but it did need to be monitored to get the right level for the right patient. And that could be very time intensive for the patient, and also quite frustrating really in their management. The other good thing about the newer oral anticoagulants is that large studies have shown that the risk of bleeding with the anticoagulants, these newer ones, is lower than with warfarin. So they are our drugs of choice in most cases. Now, having said that, there are some times that we do prefer warfarin, particularly if somebody has an antiphospholipid syndrome, and perhaps somebody's had a blood clot whilst taking a different form of anticoagulation. So there's several reasons why we might still like to use warfarin. In the first few days that somebody has a blood clot, we sometimes give heparin injections first. And in patients who've had very large blood clots, we also consider trying to dissolve the clot with something called thrombolytic treatment. So that does carry a risk of bleeding with it. So we don't do it to everybody, but if it looks like there's a lot of strain on the heart and the clot's been really large, then sometimes if we think the patient's got a relatively low risk of background bleeding, then we will try something called thrombolysis. And then very, very occasionally, if we think someone's got a massive life-threatening clot, we do occasionally go in and try and remove those clots, but that's very much in the minority of cases.